Hello everyone, welcome to our new video, and today I will be discussing the part 2 of your chapter 1 specific guidelines, which is your certain infectious and parasitic diseases. Okay, so in the part 1 I discussed your HIV or human immunodeficiency virus, and your part 2 of your chapter 1 specific guidelines is I will be discussing the infectious agent as the cause of diseases classified to other chapters. So in this part, you will going to see the code for the coronavirus. Okay, so let's start. I'll discuss the part 2 of your chapter 1 specific coding guidelines. Okay, so let's start with your certain infectious are classified in chapters other than chapter 1, and no organisms as identified as part of the infection code. So in this part of your chapter, your part 2 of your chapter 1, we will be discussing about the codes for the bacteria, code for the viruses, like that. Okay, so you can see a code for bacteria as a causative agent, because remember, most infections or all infections most of the time has this causative agent or causative factor. Okay, so since they are only a causative agent, so meaning there's an infection due to certain bacteria or there's an infection due to a certain virus. So since we are coding about the causative agents, the bacteria or viruses here, these are an additional code only to identify the organism. Because remember, when we report an infection or when we code an infection, we will going to code the infections, like for example if it's a urinary tract infection, like that. So if it's a urinary tract infection, there should be a causative agent and it should be a bacteria, like that. So you need to code first the infection and use only as additional code those code for the bacteria, because those are just an additional code to identify the organism. Okay, so a code from category B95, B96, and B97. So when you are coding additional code to code for the organism, always you can see a code for B95, category B95, B96, or B97. These are to be used as an additional code to identify the organism when present. But guys, keep in mind that you can only code B95, B96, or B97 if it's already confirmed. Okay, so if it's just suspected, they don't know the specific bacteria yet, you cannot code for B95, B96, or B97 right away. Okay, so we need to have a confirmatory documentation that this is really the causative agent before you can use B95, B96, or B97. Okay, so the sequencing, as I mentioned a while ago, like for example, if you have an infection due to a certain organism, your sequencing, your code first is the infection or the condition of the patient, followed by the code for the causative agent, which is B95 or B96 or B97. Guys, in my slide, it shows 3, B95, B96, B96. You cannot code them all unless it's all present. But it should be one only, one category only if it's just only one organism. If it's B95, so use only B95. If it's B96, it's B96 only, or B97, B97 only. But the first code should always be the condition or the infection. And common example there is like, for example, your UTI. Okay? So keep in mind those things. Okay, so just to give you an information, or you can check your book, you can go ahead to category B95. Your category B95 is Streptococcus, Staphylococcus, and Enterococcus as the cause of diseases classified to other chapters. They create a specific category for these 3 bacteria. Those are bacteria Because those are the common causative agent. Those are the common bacteria that causes infections. So they created a one category for that: Streptococcus, Staphylococcus, and Enterococcus. Of course, they have a different code. They have a different code. We have a different code for Streptococcus. We have a different code for Staphylococcus and Enterococcus, but they belong to category B95. Okay? So you may check your book for the code for Strepto, Staphylococcus, and Enterococcus. Okay, while B96 is other bacterial agent as the cause of diseases classified to other chapters. So that means that all cause or all bacteria except Streptococcus, Staphylococcus, and Enterococcus are coded under B96. All types of bacteria coded under category B96 except for Strepto, Staphylococcus, and Enterococcus because they have their own category code. Okay? So any bacteria except those three should be coded to your B96. Okay? Next, you have your B97. You have your viral agents as the cause of diseases classified to other chapters is to be used an additional code to identify the organism. Now, when we say viral agents, this is the common example here is your coronavirus. Okay, so when you are coding confirmed COVID-19 patients, okay, so like for example, the patient suffered a pneumonia because that is the common complication. There's a lot of complication, of course, of your COVID-19, but the common complication that we are encountering now is, and the cause of death most of the time is your pneumonia. Okay, so when you are coding COVID-19 patients with pneumonia, confirmed COVID-19 patients with pneumonia, you need to code first, like for example, for other viral pneumonia, you need to code first for the pneumonia, followed by the code for coronavirus. Okay, so guys, we already have a code for coronavirus because they are present already. We already have cases for like your SARS, for coronaviruses already. So we already have an available code for that. Okay, so B97. You just need to check for the code for the coronavirus. Exactly. But the category is B97. So guys, if you're coding for COVID-19 confirmed patients, you need to code first for the infection, which is like or the condition, which is the pneumonia, followed by an additional code to identify the coronavirus. Okay, so just keep in mind B95, B96, and B97 cannot be a primary code. They should always be an additional code only. So when you see choices in the exam that the first code starts with B95, B96, or B97, eliminate that. Okay? Because they are to be coded as an additional code only to identify certain type of organism. Okay? So an instructional note will be found at the infection code advising that an additional organism code is required. Just for example, you forgot that you also need to code for the organism. There's always an additional code. There's always an instructional note in your tabular list that requires you to code an additional code for the organism. So as I always mention, look at your left, look at the left side of your book, look at the right side of your book, look at up and down. That's a very important thing. You always need to be mindful of the instructional notes or any signs in your book that you can see be mindful of that, because they did not put those signs, they did not put those instructional notes without a purpose. Okay, so I have an example here, which is your UTI due to your E. coli. So remember that the common cause of your urinary tract infection is your E. coli, which can be seen in your feces, in our feces. Okay, so your code for your UTI is N39.0. The UTI is the infection or the condition. And as I said a while ago, since it's an infection and it's a condition, and it's also stated in the example that the cause is E. coli or Escherichia coli, it should be coded as an additional code only. So you have your B96.20 E. coli as the causative agent or the cause of your infection. So as you can see, it's B96 because it's not strepto, it's not staphylococcus, and it's not enterococcus. So we will going to use the other bacterial agents category, is just your B96. Okay, so let's move on. Let's move on to your letter C, infections resistant to antibiotics. Now, this is common. This is common case in the hospital. Like, you may encounter certain bacteria that is resistant to antibiotics already. So the doctor or the physician will always document if that bacteria is already resistant to your antimicrobial drugs. So many bacterial infections are resistant to current antibiotics. So it is necessary to identify all infections documented as antibiotic resistant. Okay, so if, like, for example, there's multiple infections the patient may have, and all those infections can be treated, it's already treated with antimicrobial drugs, which is already resistant to those microorganisms, assign code for category Z16, resistance to antimicrobial drugs, following the infection code only if the infection code does not identify the drug resistance. Because there are certain infections that it already tells you that this or bacteria is already an antimicrobial drugs. The common example there is your MRSA, your methicillin resistant Staphylococcus aureus. Okay, your MRSA. So in those cases, like your MRSA, it's already stated in the code that it's already resistant to antimicrobial drugs, so you don't need to code for Z16 anymore. As per your guideline, you can only code your Z16 following an infection code if the infection code does not identify the drug resistance. So be careful with that. Be mindful that if it's stated already in the first code, it's already completely documented or it's completely reported, you don't need to add more additional codes. Okay, so like for example, if you have your infection and that infection, the physician or the doctor documented that the antibiotic that they are using is already resistant to antimicrobial drugs, you need to put in your Z16 to fully report that the infection is already resistant to antimicrobial drugs. The purpose of these, guys, is it requires a higher management. It requires additional management because it's already resistant to antimicrobial drugs. So that the physician may take an additional alternative to treat your condition or infection. So it's very important to code the Z16 because these may increase the reimbursement. Okay, this is your infections resistant to antibiotics. Now, let's move on to your letter D. Your sepsis, severe sepsis, and septic shock. This is the one of the most confusing guidelines based on the exam result of my students most of the time. Okay, they are quite confused with the coding guidelines with sepsis, severe sepsis, and septic shock. These questions, these guidelines may be asked in the actual exam. So it's very important that you understand the concept of this. But keep in mind that the hierarchy should be sepsis, followed, and then you have your severe sepsis, and you have your septic shock. Meaning, the worst case scenario is if the patient's already has septic shock. And a septic shock cannot be happened without a sepsis first. So sepsis comes first. If your sepsis may result to an organ dysfunction or there's already a multiple organ failure, it may lead to your severe sepsis. And your severe sepsis may lead to your septic shock. Okay, so keep in mind those hierarchy because you always need to code the 3 or the 2. If we are talking about severe sepsis, you need to code for the sepsis and code for the severe sepsis. And you also need to code for the sepsis if there's a septic shock. You always need to code for the sepsis and severe sepsis if it's present, and the septic shock as well. Okay, so you cannot code severe sepsis without coding the sepsis first or the systemic infection. You cannot code septic shock alone without the sepsis code or a severe sepsis code if present. Okay, so just to be clear, let's start with the guideline. Coding of sepsis and severe sepsis. When we hear the word sepsis, it refers to an infection due to any organism that triggers a systemic inflammatory response and a systemic inflammatory response syndrome. So remember, if there's an invasion of microorganism in the body, your body will automatically respond. Okay, so that organism to kill those microorganisms or to defend the body. However, if the body can no longer withstand those microorganisms that enters your body, it may result into your sepsis or what we call systemic infection. Okay, when we hear the word sepsis, because there are cases like bacteremia, when you hear the word bacteremia, it's only a presence of bacteria in the blood, but that doesn't cause any systemic infection. It's different with systemic infection because when you say systemic, the infection is all throughout the body already. It involves the whole circulatory system already. Okay, that is your systemic infection. Every time you hear the word sepsis, it tells you about a systemic infection or sepsis. Okay, for cases of sepsis that do not result in any associated organ dysfunction, a single code for a type of sepsis should be used, which is your systemic infection or specific. If they tell you a specific type of sepsis, you code that specific type of sepsis. But if the cause of the organism is not yet established, you need to use your A41.9, sepsis due to unspecified organism. It's very clear in the guideline that if you do not have any associated organ dysfunction yet, your code should only be one single code for the type of sepsis. Okay? So keep in mind that if the condition is just a sepsis or a systemic infection and there's no associated organ dysfunction yet, you need to have a single code only, which is your A41.9 if the organism that causes the sepsis is not yet specified. But if they already tell you the specific systemic infection, which is rarely happening, you need to code for that systemic infection. As you can see in my slide, it says there, systemic infection or A41.9. Based on my experience in the exam and in my actual coding work I rarely use systemic infection code. Most of the time, I use the A41.9 because sometimes it takes time for the organism to be determined. Okay, that's code for your sepsis. But keep in mind, guys, that sepsis can also be happen due to traumatic injury. But in this case, in this part of our discussion, we are only discussing about a sepsis due to an organism. Remember, if every time you hear the word sepsis, it's an infection, systemic infection that caused by an organism. Okay? Next, a code for category R65.2, severe sepsis should not be assigned unless severe sepsis or associated acute organ dysfunction is documented. Okay, as I mentioned a while ago, in this, it's related with the last part of the guideline that you cannot, because the code for severe sepsis is R65.2. This is your 20 to be specific. R65.20, severe sepsis without septic shock. And we also have R65.21, severe sepsis with septic shock. Okay, take time to look at your code R65.2. Those are the code of severe sepsis. But as mentioned in this guideline, it should not be assigned unless severe sepsis is documented or an associated acute organ dysfunction is documented. Now, there are cases, since I've been mentioning that if there's so in the other guideline, you cannot code severe sepsis without organ dysfunction, meaning the opposite of that is you can only code for severe sepsis if there's already an organ dysfunction. Okay, it's the opposite. That's true, but there are cases like there's no organ dysfunction documented, but the provider documents a severe sepsis. If the provider documents the word severe sepsis, you still need to add R65.20 regardless if there's no documentation of their organ dysfunction. But if the provider documents only an organ dysfunction and a sepsis, you can code for severe sepsis R65.2 because there's already an organ dysfunction documented. Okay? So, another case that we cannot code R65.2 is if a negative or inconclusive blood cultures and sepsis. Negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in patient with clinical evidence of the condition. However, the provider should always be queried. Okay, common question in the exam, urosepsis. They usually ask, what should you do if the doctor or the physician documents the word urosepsis? The term urosepsis is non-specific term. It is not to be considered synonymous with your sepsis. Okay? So it has no default code in your alphabetic index. Even if you go to your alphabetic index, go to the word urosepsis, there's no default code for that. Should a provider use this term, she must be queried for clarification. Okay, so keep in mind, they tend to ask, what should you do if the physician or the doctor documents the word urosepsis? And the correct answer most of the time is, keep in mind, put a note, put a star in your book, you must query the provider. Okay? Next, sepsis with organ dysfunction. So if a patient has sepsis and associated acute organ dysfunction or multiple organ dysfunction, follow the instruction for coding for severe sepsis. I'll be discussing later your sequencing when we have your coding for severe sepsis. But I already touched it. Like, for example, you need to code for your sepsis, A41.9, followed by your R65.2. If there's because there's already a severe sepsis, followed by R65.20 or 0.21, for with or without septic shock, and followed by your organ dysfunction. Acute organ dysfunction that is not clearly associated with sepsis. Now, like for example, there's a sepsis and there's also an organ dysfunction. You need to make sure that the documentation associate that organ dysfunction to sepsis. The provider should be clearly specifying that that severe sepsis is related to the organ dysfunction. Because there are cases like that is not clearly associated with sepsis. Like if a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that the acute organ dysfunction is related to medical condition other than sepsis, excuse me, do not assign a code from the subcategory R65.2 severe sepsis. Okay, it's clearly stated in the guideline that you can only code for severe sepsis if that organ dysfunction is related or due to the sepsis. The documentation should always clearly stated in medical record. But you should always query the provider if you have doubt regarding your coding. So we can never assume, okay, if it's not documented, it's not done. That is the mantra of our coders. Okay, now, since we're talking about severe sepsis, we can only code severe sepsis if these are the common reason or common cases that we can code severe sepsis. There should be a minimum of 2 codes. Okay, every time you see the code, you see a documentation of severe sepsis, you always need to code for the underlying systemic infection or the sepsis code. And you can specify that there's a severe sepsis if there's an organ dysfunction. And if there's already a severe sepsis, it should always be followed by R65.20 or R65.21. Actually, the specific here is your R65.20. Okay? So, causal organism is not documented. Here's your sequencing. Okay? If the causative agent, okay, is not yet specified, meaning or the sepsis is not yet identified, the organism that caused the sepsis is not yet identified or is not yet specified, you need to use first the A41.9. So here's the sequencing if there's an additional organ dysfunction. Okay, so we have your systemic infection if it is specific already, or A41.9 if there's no specified causative organism yet. Followed by, since we're talking about severe sepsis, there should always be R65.20 followed by the organ dysfunction. Okay, but remember here, it's a minimum of 2. What if there's no documentation of organ dysfunction, but the provider documents severe sepsis? So you may code A41.9 followed by R65.20. Okay? It's still a minimum of 2. But if there's a specific already, there's a documentation already of organ dysfunction, you need to code for the organ dysfunction. So question, what if there's 3 multiple organ dysfunction already, or even 4 multiple organ dysfunction already? Code them all. The sequencing no longer matters as long as the first code should always be A41.9 followed by R65.2, and the 4 organ dysfunction can be interchanged. Okay, regardless of the sequencing of those organ dysfunction only. But you always need to code first A41.9 followed by your R65.2. Okay, that is your severe sepsis. To sum up, your code for sepsis is A41.9 only if there's no organ dysfunction and there's no severe sepsis yet. But if it's already a severe sepsis, you need to add a code for R65.2. And if there's an organ dysfunction, which is most of the time it's present, you also need to code for the organ dysfunction. Okay? That's your severe sepsis. So I have an example here. Please take time to read the scenario. Okay. The patient's diagnosis include acute respiratory failure due to sepsis. Okay, so it's very clear in the scenario that the acute respiratory failure is related to your sepsis. So what should be your first code? There's a sepsis there. There's an organ dysfunction, meaning there's already a severe sepsis, right? Okay, so when you are coding severe sepsis, what should be your code first? There's no specific organism yet that causes the sepsis, so you may use first the A41.9. Since it's already your severe sepsis, your second code should be R65.20 to be specific, because your R65.20 is severe sepsis without septic shock. Okay? And what is the organ dysfunction? That is your acute respiratory failure. It is unspecified if with hypoxia or hypercapnia. Okay? That is your example how to code your severe sepsis. Okay? Next one, septic shock. Okay, this is the hierarchy already. I mean, the highest or the worst case scenario that may happen. So it starts from sepsis. If it's not treated, it may lead to your severe sepsis. And if the severe sepsis cannot be managed, it will lead to your septic shock, which may lead to death. Okay, so your septic shock is a circulatory failure associated with severe sepsis. Connection start with sepsis, severe sepsis, and septic shock. So the type of acute organ dysfunction, underlying systemic infection should be sequenced first, followed by your R65.21, severe sepsis with septic shock. I've been mentioning this a while ago, since I've been mentioning about R65.20 if without septic shock, R65.21 if with septic shock. So every time you see the word septic shock, hey, I need to code R65.21. But remember, before there should be a septic shock, there should be a sepsis first. So, meaning, you need to code for the sepsis first, followed by your severe sepsis with septic shock, which is your R65.21, followed by an organ dysfunction, which is usually it's present. Because you can, most of the time, if you already have a septic shock, this may cause multiple organ failure already. So, okay? So, systemic infection or A41.9 first, followed by R65.21 or T81.2. Guys, your T81.12 rather is your post-procedural septic shock. Meaning, they do a certain surgery, they do a certain procedure, and this leads to your septic shock. And again, remember, a septic shock can happen if there is a sepsis. Okay, there's a tendency right after the procedure that the patient may suffer a post-procedural septic shock, but it should always be documented in the medical record. And it should be followed by your organ dysfunction. Okay? So, yeah, we have an example here. Okay. A patient is admitted with severe sepsis, septic shock, and acute respiratory failure, and metabolic encephalopathy due to the sepsis. Okay. So in this case, there is a sepsis, severe sepsis rather, there is a septic shock, and there's already an organ dysfunction. Okay, so since we're talking about septic shock, is there an organism specifying the cause of your sepsis? So we don't have yet. So your first code should be, remember, code first for the sepsis, followed by severe sepsis with or without septic shock. With. So you need to use your R65.21, followed by your organ dysfunction. And how many organ dysfunction do we have? We have acute respiratory failure, and you have your metabolic encephalopathy. It is stated that those organ dysfunction is related to your sepsis, so you can code them both. Correct? Yes. So you need to code first your acute respiratory failure or metabolic encephalopathy. Doesn't matter as long as you need to code them both, and as long as the first two code is correct. Okay? So I can code first acute respiratory failure, followed by your metabolic encephalopathy or more organ dysfunction if there are additional organ dysfunction indicated in your scenario. Okay, so that's how easy is this. It starts from sepsis, followed by severe sepsis, and the highest part is, or the worst case scenario is, your septic shock. Okay, that is how you code your sepsis, severe sepsis, and your septic shock. Okay, so since we've been mentioning a while ago the sequencing of severe sepsis, if severe sepsis is present on admission, this guideline is for inpatient guidelines, but it's nice to know, guys, if severe sepsis is present on admission and meets the definition of principal diagnosis, the underlying systemic infection code should be assigned as the principal diagnosis, followed by the appropriate code for R65.2 if there's a severe sepsis. If the reason for encounters for the sepsis or with the severe sepsis, code for the systemic infection or the sepsis first, because that's the reason for infection. That's the reason for admission. A code for R65.2, as I mentioned, can never be assigned as principal. Okay, because you cannot code an R65.2 which is severe sepsis without the code for sepsis first. Remember in our discussion. Okay. But if the severe sepsis develops during an encounter, meaning it's just developed there. The condition only develops during the encounter. So meaning there's a different reason why the patient came into the hospital. So you can only code them as a secondary, because there are other reasons why the patient came into the hospital, because that severe sepsis only develops during the encounter already. Okay, this is for your inpatient guidelines. Okay, severe sepsis may be present on admission, but the diagnosis may not be confirmed until sometime after admission. So if the documentation is not clear whether severe sepsis was present on admission, the provider should always be queried. Okay, what if sepsis, next guideline, sepsis or severe sepsis with a localized infection. So remember, as I mentioned a while ago, when we say systemic, it's already throughout the body. Infection throughout the body. That's throughout your circulatory system already. But it can also happen that you already have a systemic, plus you may also have a localized infection. Okay, so double jeopardy. Okay, you have your systemic and you also have your localized. So what if those are the scenario? Because it happens. Okay, so the sequencing guideline is, if the reason for admission is both sepsis or severe sepsis and a localized infection, if the reason for encounter is both of them, okay, so you need to code for systemic infection, localized infection, followed by R65.2, and your organ dysfunction. So if the reason for admission is both sepsis and severe sepsis and a localized infection, code first the highest severity, which is your systemic, followed by your localized. Okay? But If the patient is admitted with a localized infection, meaning the reason for encounter is really the localized infection, such as pneumonia, and severe sepsis doesn't develop after admission, so you need to code first your localized infection, followed by systemic if the systemic infection develops during the encounter, followed by a severe sepsis code if present, and followed by organ dysfunction if it's indicated that the organ dysfunction is related to your sepsis. Okay, see the guideline? They are related in our first discussion. Okay. Sepsis due to a post-procedural infection. So guys, keep in mind that the patient suffered a sepsis due to a surgery, due to a procedure. So you always need to base the causal relationship on the documentation. Like the doctor must admit that that post-procedural infection is due to the surgery that they do, okay, or the procedure done. Okay, it's very important, guys, that they should always document the causal relationship, because we can never assume. Okay, they may sue us, okay, when we're coding like that, if it's not really the cause of your post-procedural infection. Okay, sepsis due to post-procedural infection, and your code for post-procedural infection or sepsis due to your post-procedural infection is your T81.40 to T81.43. For our pregnant patient, you have O86.00 to O86.03. Assign additional code for sepsis following the procedure or sepsis following the obstetrical procedure, and the additional code should always be your infectious agent if it's available. If the severe sepsis, then the appropriate code for R65.2 should always be assigned. It is the same guidelines, guys, with the first discussion a while ago. Like when we have a systemic infection, your code, or sepsis, your code is A41.9, correct? And if there's a systemic severe sepsis, rather, it should be followed by R65.2, correct? And if there's an organ dysfunction, you also need to code for the organ dysfunction. Now, if that is caused by a systemic infection or sepsis, now here is very specific that the cause of sepsis is due to your post-procedural infection. So you need to change A41.9 to T81.40 or T81.43. And it's still the same if there's a severe sepsis followed by R65.2 and your organ dysfunction. See the difference? Eliminate A41.9, change it with T81.40 or T81.43. Or if it's a pregnant patient, you need to code O086.00 rather to O86.03 followed by R65.20 and any organ dysfunction. It's the same thing. Okay? You just need to change A41.9 into T81.40 or T81.43. Are we clear with that? Okay. Next, post-procedural infection and post-procedural septic shock. It is the same guideline when you have your septic shock in our first discussion. Just that you need to change your first code, your R65 into T81.12. Okay? You no longer need to code R65.21, severe sepsis with septic shock, because there's a specific code for septic shock due to your procedure, which is your T81.12 post-procedural septic shock. Additional code may also be used to identify organ dysfunction. Okay? But if the procedural infection has resulted in post-procedural shock, assign the codes indicated above. For sepsis due to post-procedural infection, you still need to code for the T81. Okay? T81.40 to T81.43, if that's the reason for infection, followed by T81.12 instead of R65.21. And you also need to code for your organ dysfunction. Hopefully this clears, guys. As long as you know the reason, the guideline with the first discussion that we have regarding sepsis, severe sepsis, and septic shock, you're good to go with this. Okay? Like for example, when you use T81.12, of course you no longer need to use R65.21 because those are already redundant already. Okay? Sepsis and severe sepsis associated with a non-infectious process. I mentioned a while ago that Sepsis most of the time is caused by an infectious agent or an organism, but it can also be caused by a trauma or injury. So in this case, you just need to change A41.9 into trauma. Okay, plus the resulting infection. And if there is a severe sepsis, you also need to code for severe sepsis and organ dysfunction if present. In some cases, a non-infectious process condition such as trauma may lead to an infection which can result to a sepsis or severe sepsis. So, trauma resulting to an infection, resulting to your severe sepsis, and resulting to your septic shock. So, there's no A41.9 that there already because it's not caused by organism. Okay, in this case, it's caused by a non-infectious process or it is caused by trauma. Okay, if sepsis or severe sepsis is documented as associated with a non-infectious condition such as burn or serious injury, this is a common case, and this condition meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, like your burn or your serious injury, followed by a code for any resulting infection that may happen. And if severe sepsis is present, a code for R65.2 should also be assigned with any associated organ dysfunction. It is not necessary to assign a code for subcategory R65.1. It's the same process. Okay, as you can see, but you just need to change the A41.9 into a traumatic injury resulting into infection. And then severe sepsis is the same thing. You need to code R65.2. And if there's an organ dysfunction, you also need to code for the organ dysfunction. Okay? So here's the sequencing. Injury, like burn, resulting infection, if any infection that may happen, followed by R65.2 if there's an organ dysfunction, or if it's already a severe sepsis. And remember, your keyword be that you can already code for severe sepsis like R65.2 if there's already an organ dysfunction. But if there's no severe sepsis, you can just code injury and resulting infection. Okay? But if it's severe sepsis, you need to code R65.2 and organ dysfunction. Okay? Okay, letter E, methicillin-resistant Staphylococcus aureus or your MRSA conditions. Okay, this is a common case. Selection and sequencing of MRSA code. It's a combination code for MRSA. Remember when I discussed in my second video about your combination code? Your combination code meaning in just one code you are already coding two diagnoses, or you are coding your etiology and manifestations like that, or you're coding a condition followed by a secondary manifestation. So those are combination code. So we have here a combination code example here is your A41.02. When you say A41.02, the definition of there is your sepsis due to methicillin-resistant Staphylococcus aureus or sepsis due to MRSA. As you can see in the definition of the code, you can see the condition which is sepsis, correct? Sepsis. Remember, we have a code for sepsis, A41.9, but since it's already, A41.9, if the organism is not yet established or not yet specified. But here in this example, A41.02, it's already stated that the sepsis is due to your MRSA. So it's a combination of a condition plus the causative agent. Okay? So in this case, you don't need to code for MRSA or you don't need to code for the code for Staphylococcus aureus, which is your B95. You no longer need to code for your resistance to antimicrobial drug because remember, methicillin is an antimicrobial drug, right? Because it's already redundant. Okay? You can no longer use the B95.62 and Z16.11 in these two examples because it's already stated in the code description. Okay? J15.212 is another example. You have pneumonia due to methicillin-resistant Staphylococcus aureus. In this case, the condition is pneumonia, correct? And the cause of that is your MRSA, correct? Okay, it's stated that it is methicillin resistant, so you must have a code for Z61.11 most of the time, but it is already stated in this code description that it is already due to methicillin-resistant Staphylococcus aureus, So you no longer need to code for your Z16.11 and your B95.62 because that may result in redundancy. Okay? So I just need to remind you guys that there are combination codes. Keep in mind that if there's a combination code, meaning it already describes everything, and there's no instructional to code anything, additional code, there's no instructional note that you also need to code for any condition, you no longer need to code your, use an additional code because it's fully identified or fully described already in just one combination code. Okay? Other codes of MRSA infections, however, there are cases like there's no combination code. Okay? So in those cases like there's no combination code, you need to code them separately. Like you have your condition followed by due to your MRSA, but that condition we don't have any combination code for that, so you need to code them separately. So you need to code for the condition followed by B95.62. The condition here is you can no longer code for the resistance because it's already stated in your B95.62 that this is already a methicillin resistant Staphylococcus aureus infection code. Okay? If there's no combination code, code them separately. As we discussed in the guideline, in the general coding guideline, that you can only code your combination code if it fully describes the whole scenario. But if it doesn't describe the whole scenario, you have no choice. You need to code an additional code for that to fully describe the entire visit or the entire scenario. Okay? There are also, since we're talking about methicillin resistant, we also have methicillin susceptible Staphylococcus aureus, meaning you have that bacteria, but that bacteria doesn't cause any diseases or any disease with you. I'm not sure if this is true with COVID-19, I'm not yet sure, but remember there are cases like asymptomatic, so those may be a carrier, but the conditions may not happen to them. So I'm not sure yet with those guidelines or with those theory. Okay, so methicillin susceptible, you may have the bacteria, but that bacteria doesn't cause any illnesses to the patient. Okay, so that is what we call susceptible or colonization. Colonization meaning present in the body without necessarily causing illness. So the common example, if you are MRSA screen positive, MRSA nasal swab positive, but you don't have any signs and symptoms yet. This is very common now as I encounter with COVID-19 cases. There's a lot of positive cases, but there's no signs and symptoms yet. Okay, so those are colonization. You are just carrier. So your MSSA. Methicillin susceptible Staphylococcus aureus, MSSA, and MRSA colonization codes. You have your Z22.322. You have your carrier or suspected only for methicillin resistant Staphylococcus, and Z22.231 if you're suspected or carrier of methicillin susceptible Staphylococcus aureus. Patient having MSSA colonization. The bacteria is present in your body, but it doesn't cause any illness or any signs and symptoms. Okay. MRSA colonization. What if there's a colonization and there's an infection? Code the infection first because that is the higher severity. If the patient has both MRSA colonization and infection, code the infection and code also the colonization. The sequencing is you need to code the infection first followed by the colonization. Okay.